And so here we go. You're muted, Nate. So
there we go. There
Yep.
you go. Now you can hear me.
Yes.
All right. Thanks, Greg, for that really nice introduction. Welcome, everyone. Good afternoon. It is my privilege today to kick off our session on using and adapting the leadership and organizational change for implementation strategy, which we call LOCI. So I'm going to say LOCI a lot in the next 15 minutes across 2 hybrid trials in children's services. So I'm going to kick us off sharing about the Wisdom Hybrid Type 3 trial, which I led, and then I'm going to turn it over to Lauren to share about the TEAMS trial. So jumping right in, Wisdom stands for working to implement and sustain digital outcome measures. So that gives you an idea of where we're going with this trial. It was funded by the National Institute of Mental Health, and we're grateful for their support, and I don't have any other conflicts of interest or disclosures to report. So the implementation problem that we tackled in the Wisdom trial had to do with insufficient uptake and fidelity to an evidence-based practice called measurement-based care. For those who aren't familiar, in mental health settings, measurement-based care involves administering a standardized symptom rating scale to a patient prior to or during every session, and doing that consistently over time and using the feedback from those measures to guide clinical decision-making. Digital measurement-based care systems take that whole process and digitize it. So the measures are completed electronically on a tablet, a phone, a computer. They get scored instantaneously by the system, which clinicians love. And the most sophisticated digital measurement-based care systems produce an empirically based feedback report for clinicians that's based on an actuarial algorithm that actually can monitor a patient's progress over time relative to an expected recovery curve and can predict with a high degree of accuracy whether that patient is on track, looks good, everything's going well, keep doing what you're doing, or whether that patient is getting so far off track that we know empirically they're very likely not to benefit from services or to drop out. And so we know from dozens and dozens of randomized controlled trials that this type of feedback to clinicians in mental health settings improves the outcomes of care. But like many evidence-based practices, it is not widely used, particularly with youth, which was our population of interest. And so we wanted to see if we could do something about this in the Wisdom trial. And one of the things we saw in the literature on barriers and facilitators to implementing measurement-based care is that organizational issues, leadership, culture, climate, those kind of organizational factors were really, really important determinants. And so we decided, let's design a trial that will test an organizational implementation strategy that directly targets those things, which LOCI does. So aim 1 in our trial was to test the effects of the LOCI strategy on improving fidelity to measurement-based care at the youth level, as well as youth symptom improvement. We focused on outpatient mental health clinics serving youth. And then in aim 2 of our trial, we dove into the mechanisms that explain how LOCI influences fidelity. Mechanistic tests are really important in implementation science for elaborating and confirming, disconfirming our theories, also for refining our implementation strategies and making them more important. So that was our second aim. Really quickly, just to mention, the digital measurement-based care system that we studied in our trial is called the OQ, the Outcomes Questionnaire Analyst. Some of you may be familiar with that. It comes out of the work of Michael Lambert and colleagues. So let me tell you a little bit about the LOCI strategy. LOCI is a 12-month organizational implementation strategy. Here you see how it unfolded in the Wisdom trial. I like to say that LOCI, I was going to say it was developed by Greg Ahrens and Mark Earhart and colleagues, which you already heard that. I like to say that LOCI has 2 key components. The first component is leadership training and coaching that's provided to first-level leaders. First-level leaders are those who directly supervise clinicians. Typically, they provide administrative supervision and oftentimes clinical supervision as well. But the goal with LOCI is to train these first-level leaders in skills that will help them support implementation. And there's 2 kinds of leadership skills that LOCI focuses on. The first is a general set of leadership skills called transformational leadership. This comes out of the full range leadership model by Bass and Avolio. And these are really skills about just generally, how do you motivate and inspire the folks that you're leading to develop a shared vision and go along with that vision and that plan? How do you really engage them in a motivated way? And so LOCI focuses on training in those transformational leadership skills. And also it focuses on a set of skills we call implementation leadership skills. And these are more focused leadership skills that are really about how do you lead the implementation of a specific evidence-based practice, in this case, digital measurement-based care. So LOCI provides quarterly trainings to first level leaders in these skills. And then in between trainings, first level leaders participate in weekly individual coaching calls. These calls last about 15 minutes, so they're brief. And they really focus on helping the leader work on their leadership development plan and troubleshoot implementation issues as they go along. The calls are with the LOCI trainer, facilitator, so it's all part of the intervention. Once per month, those individual coaching calls are replaced by a group coaching call where we brought together all of the first level leaders in the LOCI condition, oftentimes around a theme, and allow them to share expertise and insights as they're all working to implement an evidence-based practice in their settings. The second key component of LOCI are monthly organizational strategy meetings. These meetings involve all levels of leadership within the clinic, from executive level all the way down to first level leaders. And they really have two main goals. The first is to generate alignment across levels of leadership. We want all the leaders within an organization sending a consistent and unified message about the importance of implementation. And we want those upper level leaders actively supporting and backing up the efforts of the first level leaders as they're trying to guide implementation within their clinic. The second goal of the organizational strategy meetings is to help the leadership team think together about what are the organizational policies, procedures, and practices that they can put in place to help generate an implementation climate within their clinic. For those who aren't familiar, implementation climate is a type of focused organizational climate. It exists when the clinicians within a setting perceive that they are expected, supported, and rewarded to use a specific evidence-based practice with high fidelity. They're really convinced it's the real deal, it's something we're doing, and they need to get on board. So those components of LOCI are really directed at activating some of the key mechanisms which you see here in LOCI's theoretical model. I want to stress that LOCI can be applied to organizations large and small. In the Wisdom trial, we applied it to clinics. So that's, you see kind of a scaled down version here applied to the clinic level. But the idea here is that LOCI tries to activate two different components at the organizational level, two mechanisms at the organization level that we think are important for facilitating implementation. The first there, you see that the first node coming out of LOCI is changes in clinic first level leadership. So by providing that training and coaching, the idea is that we're going to improve the leadership behaviors that clinicians are exposed to within their practice setting. Those changes in leadership, in turn, along with the other pieces of LOCI that we talked about, are believed to contribute to the formation of an implementation climate within the clinic. Once that implementation climate, or as that forms, and once that's formed, we believe that then contributes to changes in providers' behavior, clinicians' behavior, which ultimately translate into different care experiences by patients, in our case, youth experiencing higher fidelity to digital measurement-based care. And then once we improve fidelity, we think that's going to subsequently improve the clinical outcomes. So what we're going to do today for the Wisdom trial, we're going to walk through and systematically test the components of this model and show you the data that we collected. So first, we'll look at LOCI's effect on our primary youth level outcomes of MBC fidelity and youth symptom improvement. Then we're going to shift into a mechanistic focus. And here we will first, whenever you want to test mechanisms, the first thing you need to do is confirm that your strategy activated the thing that you think is a mechanism. So we're going to first confirm that LOCI improved first level leadership. We're then going to confirm that LOCI improved clinic implementation climate. And once we've done that, we're in position to test our first mechanistic hypothesis. And the first one we're going to test is that improvements in first level leadership earlier on in the trial will mediate or explain the effect of LOCI on subsequent effects on the clinic implementation climate. And then finally, our last mechanistic hypothesis we'll test is LOCI's main mechanistic hypothesis, which is that improvement in clinic implementation climate throughout the LOCI period will mediate or explain LOCI's effect on youth level fidelity. So a little bit about the wisdom study design to kind of give you an idea of what we did. It was a cluster randomized hybrid type 3 trial. We enrolled 21 outpatient mental health clinics that were serving youth, and we randomly assigned 10 of them to a control condition and 10 of them to the experimental condition. We did collect data in 2 phases. We're only going to look at phase 1 data today. All of our clinics that were enrolled in the trial received initial training and then 12 months of technical assistance to implement the OQ system. And so that training, and there was initial training, a couple of booster trainings, that was provided by the OQ purveyor organization, and they also provided the technical assistance. So everybody, all 21 clinics in the trial got that all the same. The only difference between the 2 conditions is that in the LOCI group, their leadership participated in the LOCI strategy. To help us look at our primary youth level outcomes, we enrolled new youth outpatients who entered services after the MBC training, and we followed those youth for 6 months after their baseline. We collected data on MBC fidelity for each youth directly out of the OQ system. So the OQ system automatically logs every time a measure is completed, whether the feedback report ever gets looked at, and the timing of when the feedback report got looked at. So we were able to use that data for each youth within their 6-month period, and based on the number of sessions we knew they had from caregivers, we created a fidelity index ranging from 0 to 100%, which indicated how much fidelity to MBC the youth experienced. We also tracked changes in youth symptoms. Caregivers completed research measures at the youth's baseline and then monthly thereafter for 6 months, regardless of treatment participation. To help us look at our mechanisms, we collected data from clinicians. So they completed ratings of the first level leadership within their clinic and also their clinic's implementation climate. They did this at baseline, 4 months, 8 months, and 12 months, which coincided with the end of LOCI, and then a 6-month follow-up, which was 18 months after baseline. COVID did hit early on in our trial, and we think we see the effects of that a little later on when we get to our results, but we were able to finish our study. So let's dive into our results. In the upper right, you see a little miniature version of our model that's going to help you keep track of where we're at in our model. So first up, looking at LOCI's main effects on youth level fidelity, I said it ranges from 0 to 100%. Here you see the average fidelity in each condition, 23% in LOCI versus 3% in control. So statistically significant, really large 20 percentage point difference in fidelity. We were thrilled with that. It gives us evidence that LOCI improved fidelity, and it's a very large relative difference. Also means we can test our mechanistic hypotheses. We were disappointed though, because we wish the fidelity in the LOCI condition was 75%, right? But we think that that's a COVID effect. These clinics were competing with a lot of stuff during this year of our study. And so that's why we do experiments though, right? Is so those historical confounds are controlled. But we did see that large relative effect of LOCI on fidelity. Moving on to look at LOCI main effects on youth symptoms. This is looking at youth symptoms over time from baseline to 6 months after. Solid orange line is LOCI, dash gray line is control, lower symptoms is better. Both groups improved significantly from baseline to 6-month follow-up, but the improvement was significantly greater in LOCI. The Cohen-D effect size here is 0.31, so that's a small effect size, but it's a very respectable effect size in youth psychotherapy research. So we were pleased to see that LOCI had a significant main effect on improving youth symptoms. Diving into our mechanistic analyses now, first step is to confirm that LOCI activated those first level leadership dimensions we were interested in. Here you see clinician ratings of implementation leadership by condition over time. The solid orange line is LOCI. Again, you see baseline equivalence between the 2 groups, but by 4 months, implementation leadership had improved significantly more in LOCI relative to control. That was sustained throughout the 12-month LOCI strategy period. Large effect size of Cohen-D 1.18 there, so that's a really big effect size. Dipped a little bit at the follow-up, but still a large effect size. So very robust effects of LOCI on implementation leadership over time. Turning now to look at ratings of transformational leadership. Here again, solid orange line is LOCI, and we see the same pattern. Significant effect of LOCI by 4 months, but the Cohen-D effect size here is only 0.31, so that's a small effect, and it's not statistically significant after the 4-month mark. So weaker effects of LOCI on transformational leadership, enough that we can still test our mediation hypothesis because it changed at 4 months, but definitely a weaker effect here. And then finally, looking at LOCI effect on implementation climate over time, we see the same pattern. The effect size here was large at 12 months, 0.98, and dipped a little bit at 18 months, 0.76, but still a very robust effect of loci. So now we've confirmed that loci affected those two mechanisms that we think might be important, so we can dive into our first mechanistic analysis. So our first mechanistic analysis, this is a mediation model. And our endpoint here is the improvement in clinic implementation climate from time 1 to time 4, which is 0 to 12 months. And we're testing whether LOCI's effect on improvement in climate was mediated first by the earlier improvement in implementation leadership from time 1 to time 2, or from 0 to 4 months. So we tested that model using mediation analysis, and there was a statistically significant indirect effect, so mediation is present. And our effect size measure is this proportion mediated here, which we see as 0.82. What that means is that 82% of LOCI's effect on implementation climate at 12 months was explained by the earlier improvement in implementation leadership at 4 months. 82% of LOCI's effect on implementation climate was explained by the earlier improvement in implementation leadership. So that hypothesis was supported. Looking now at transformational leadership, we did not see a statistically significant indirect effect, so that wasn't supported. So what we have here is evidence of specificity, right? If you're a first level leader and you want to create an implementation climate within your clinic, these data are suggesting the way you do that is by really using those implementation leadership skills. Finally, moving on to our last hypothesis. Here we have youth level MBC fidelity as our endpoint, and we're looking at the change in clinic implementation climate from time 1 to time 4 as our mediator. So is the improvement in climate over time mediating LOCI's effect on fidelity during the same time period? Here again, we do see a statistically significant indirect effect, and our proportion mediated is 0.71. So what that means is 71% of LOCI's effect on youth level fidelity, which was measured through the OQ system, was mediated or explained by the improvement in implementation climate across that time period, which was rated by clinicians. So very strong evidence here supporting LOCI's primary mechanism, and suggesting if you want to support digital measurement-based care implementation, a really helpful way to do that is to create a clinic implementation climate. So key takeaways, I'm going to speed through these so we can get to Lauren. First, we have evidence that LOCI, in sort of a standard implementation of LOCI at work, it affected those bottom line implementation and clinical outcomes. The theorized mechanisms were mostly supported. We saw the support for implementation leadership contributing to implementation climate, and implementation climate contributing to fidelity. So we saw that. And now that we know that knowledge is really practical in terms of applications. We can do pre-service training, graduate training about implementation leadership, implementation climate, those kind of things could really have a lot of practical applications. But I'm going to stop there so that I can turn it over to Lauren.
Thanks, Nate. I'm going to just take a minute to share my screen.
Yeah, and as I mentioned in the chat, you can put questions in the chat or save them up for the end. We'll have questions on both talks. So thanks. Go ahead, Lauren. Thank you.
Thanks. I really like presenting after Nate's already described LOCI. So this is fabulous. So I'll be talking about a separate, actually a set of trials that included an adaptation of LOCI for autism interventions in public schools and in community mental health clinics and programs. So this was funded by two R01 trials from the National Institute of Mental Health. One was led by Dr. Auden Stamer, and I led the other trial, and they were linked together. So our trials were run together in collaboration. So just some background as far as autism being a public health priority. We know that the prevalence of autism has been increasing. There's estimated very high costs of care provided to this population. There's been a considerable number of evidence-based practices designed, developed, and tested for autism, but as we know from other clinical populations, that there's gaps between the evidence-based interventions that have been developed and what routine care looks like. So in our context, we like to talk about really that care, the different systems of care that are involved for caring for autistic children. Our studies are focused on two public service systems that care for autistic children. One is mental health. So we're primarily talking about outpatient and school-based mental health. That system is responsible for caring for the high rates of co-occurring social, emotional, and psychiatric conditions and needs in this population. And then also the education system that provides a significant amount of care for this population. So there are multiple service systems that care for autistic children. We're focused on mental health and schools. So Dr. Stamer and I were working in two different contexts. I was focused on mental health programs. Aubin was focused on schools. We independently but simultaneously developed or adapted two clinical interventions for autism. And we developed and adapted these interventions in collaboration with community providers, parents, leaders, for specific delivery in the service systems in which we were working on. So CPRT stands for Classroom Pivotal Response Teaching. Aubin led the development or the adaptation of Classroom PRT, and I led the development of AIM High, so an individualized mental health intervention for autism. So these interventions were developed, again, based on feedback from partners and designed for delivery in specific service systems. We each tested these interventions separately in large-scale effectiveness trials, and we found very similar findings in that when we trained providers in our interventions, that we saw improved child outcomes, we saw greater provider use of evidence-based intervention strategies, we saw that fidelity was associated with child improvement, but that there was variable fidelity in for teachers in Aubin's case and for mental health providers in my case for AIM High. So we started to look at some common influences on implementation outcomes in our separate trials. And what we found was influences at multiple levels. First, the importance of leadership support and engagement, and then provider attitudes and motivation. And so that led us to combine forces and to coordinate a project that was testing implementation strategy to further improve provider fidelity and training engagement, which leads me to the TEAMS trials. So what the TEAMS trials were two linked studies in which we were really examining the impact of pairing AIM High, in my case, CPRT, in Aubin's case, their training with a leadership intervention or a provider engagement intervention to see if it impacted the delivery of AIM High, CPRT, and child outcomes. So I'm going to focus more on our leadership intervention, but I will talk about our other implementation strategy. So I'm not going to describe LOCI because Nate did a wonderful job already describing that. For teams, we adapted LOCI. I believe Greg has used the term LOCI Light for our Teams Leadership Institute. We made a number of adaptations to LOCI. So first of all, we selected specific modules from LOCI in that we focus on implementation, climate, and leadership modules only. And then we also focused on evidence-based practice specific implementation support. We reduced the intensity and length. So Nate talked about a 12-month intervention. Ours was 6 months with less frequent coaching sessions. We added some structure to our coaching to support adherence to the program. And then rather than targeting one leader per district or for clinic, we really engaged leadership teams. So the coaching was often with teams of leaders for within a given district or within a given program. And so again, this is about 6 months of the intervention, whereas the full LOCI is 12. So that was our leader organization level intervention. We also adapted our gold standard training approaches to focus on provider motivation and engagement. And so what we did is we took evidence-based motivational interviewing strategies and integrated it into our existing training strategies that were really geared toward, again, enhancing provider motivation and engagement. So what we were interested in looking at is the individual and combined effects of Teams Leadership Institute and our TIPS version of our training on 3 main outcomes. So our primary outcomes were implementation outcomes, so evidence-based intervention certification. So whether the teachers or mental health providers completed our 6-month training process for our clinical interventions, and whether they reached a fidelity threshold that was rated by our coaches. And then we also looked at observed evidence-based intervention fidelity. And so that was where raters who were naive to the condition that the therapist or the teachers were in were rating a random selection of video recorded sessions between a child and their provider. And then we also looked at child outcomes, and we had different outcome measures for the 2 different studies, but standardized their scores so that we could combine their data. We are also looking at engagement of targeted mechanisms. These will sound familiar for the Teams Leadership Institute. We looked at implementation climate, implementation leadership, and then by EBI specific, I mean CPRT specific or AIM High specific implementation support strategies that the leaders used as they were those interventions were being rolled out in the clinics or in the schools. We also were interested in the effects of teams on, or of TIPS on provider attitudes and motivation. That was the target of that implementation strategy. And then we were also looking at kind of the mediation effects of those indirect effects of those mechanisms on our targeted outcomes. So methods. We also conducted a cluster randomized trial. We enrolled programs and school districts over 3 cohorts, and then at each cohort we randomized districts we enrolled them and then randomized them. We randomized these districts and programs into one of 4 conditions. The first condition was gold standard training. Then there was a provider enhanced training where TIPS was used, a leader training where we included the Teams Leadership Institute, and then our last condition is where they had both. The clinical training was provided in all the programs and districts for about 6 months each. So our combined participants included 385 dyads of providers and families. And so we had the providers enroll with 1 child, so for the purposes of the design. So what did we find? For our implementation outcomes, we did not find an effect of TLI or TIPS on certification. So whether or not the therapist or the teacher completed the 6 months of training, we did not find an effect there. But what we did find is an effect only of TLI on observed fidelity. So again, those were those video recorded sessions where we had observers naive to the condition to rate the extent to which the therapists were using key strategies from each of the interventions. And then we also examined the effects of TLI and TIPS on improvements over 6 months in child outcomes. And we found that there was a significant effect of TLI on improvement. And this is improvement means reductions of scores in both of the studies. And so we saw a strong effect of TLI only on child outcomes. And then we also examined whether we engaged our targeted mechanisms. And so we did not find an effect of TLI on the implementation leadership, but we did find an effect of TLI on the implementation climate and an EBP or EBI implementation support strategies. We also collected some, we did not find any significant mediation of or indirect effects of those targeted mechanisms of TLI. But we did collect some qualitative data to understand what the leaders' perspectives are on how TLI worked for them as they implemented either CPRT or AIM High. And one of the initial themes was that the leaders felt that the structure of TLI provided some accountability that they felt was really helpful in and moving forward with the progress and goals and to keep them on track. They also felt like, and I think Nate mentioned this as well, that an important aspect of LOCI and TLI was alignment. And they felt that the alignment of leaders, having everybody on the same page was really an important component of TLI. So as far as a summary of the significant teams finding, we did see that TLI was associated with higher provider fidelity and better child outcomes, so greater improvements, and this is over the course of 6 months. And that we engage those mechanisms of implementation climate and EBP specific implementation support. Again, we did not see effects of TIPS or an indirect effect of our targeted mechanisms on our outcomes. We are in the process of conducting 2 extension studies of teams, which are focused on further adaptations of our Teams Leadership Institute. I don't have time to get into those in details, but I will share that one of our adaptations involves a focus on selecting evidence-based practices and using evidence-based practice registries in order to select evidence-based practices for the needs of a given school district or mental health program. That's currently underway. And then we've just launched a further extension of the Teams Leadership Institute, where we've modified or further adapted it to focus on an implementation team, not just the leaders, but other team members that would be that may be essential, such as clinical supervisors or clinical leads or other staff that wouldn't participate in the Teams Leadership Institute, but would be important for implementation and targeting increased teamwork between or effective teamwork between them. So those are extension studies that are currently underway. I should acknowledge that the Teams trial took a huge amount of teamwork across UCSD, UCLA, and UC Davis, and many, many, many community partners. And we're continuing to use the infrastructure that we developed for the Teams trial and the adaptations that we did for LOCI as we move forward in furthering the development of implementation strategies. So with that, I'll just end with a couple of comments on bringing things together between the teams and the wisdom trials, in that we have multiple hybrid 3 trials in public service systems with multiple EBPs. We saw the positive effects of full loci and the abbreviated loci on fidelity and child outcomes. Really illustrates that loci is flexible and can be paired with multiple EVPs in different formats and configurations. And I think just really the bottom line is the importance of proactive support and coaching for leaders in supporting providers as they learn and deliver evidence-based practices. So I think with that, I ended right on time to be able to open it up for questions and discussion.
Yeah, thank you, Nate and Lauren, for those great talks. And yeah, so we've got, gosh, a little over 15 minutes for questions, comments. I'll just pause.
I should have put in my summary, I'll just add that another theme across these trials was persisting during COVID and supporting, continuing to launch these large-scale trials during COVID, and also supporting leaders as they were really grappling with especially the onset of the COVID pandemic, and the impact on schools and children's mental health was significant.
Okay, so questions are starting to come in the chat. So Irene Sue is asking, in both trials, do you have some tips for getting participants to repeatedly complete surveys on implementation climate?
Do you want to go first, Lauren? I can.
You can go.
I'll take a shot. So we had, in the Wisdom trial, we collected 7 surveys from caregivers of youth who were outpatient. The youth were the outpatient and the caregivers reporting on the youth. So we collected baseline and then once per month follow-up for 6 months. The caregivers completed the standard symptom measure, I think, has about 40 items, and there's about 12 more items on therapeutic alliance and which I didn't talk about. And there was a few more questions about treatment participation, things like that. So not a small survey for parents to do. And we had phenomenal success rates. We had over 80% on every single follow-up. And the other thing that we looked at is, by the way, Stata has some really cool functions to help you look at your longitudinal data and patterns of missingness and kind of see it in a visual format. And we had folks, it wasn't sort of this linear thing like once you drop out, now you're gone forever. We would follow up with people unless they told us, leave me alone, which didn't happen very often. But if they told us that, of course, we would be respectful and not contact them anymore. But we would have people who would miss 1 or miss 2, but we would persist with them unless they formally withdrew. So I would say that's one strategy, is to persist with folks in a respectful and appropriate way. But the other thing that I would say that helped us was staff, right? The folks that you have interacting with your participants are absolutely essential. And I mean, it's kind of good customer service 101. Like, how do you treat people with care and respect and make them feel valued and help them understand the importance of what they're doing and what they're participating in? Having the automatic follow-ups that happened. We use the Qualtrics system for our stuff, and it would and reminders that would occur for the parents every month, that they would get an auto-generated email. Okay, it's time to do your next thing. And then we had staff tracking whether or not those got completed and doing telephone calls if they didn't happen within a certain period of time. We also gave people an incentive every single time they did a survey, and we made sure that we got those promptly, and that if people don't have problems getting those. I mean, these sound like overly simplistic and basic things, but I really think that kind of attention to the detail, those customer service kind of things, were really, really important for us in having that really, really good response from caregivers of youth who are receiving these mental health services. The other thing I'll say on the clinician side, we had clinicians who completed about 180 to 200 questions on their surveys, so very large surveys. They did that 5 times over a year and a half. And what we did with clinicians that I think really helped was one of them was escalating incentives. So they got a certain amount for the first 2 times, but then we started to bump it up, and not by an insignificant amount towards the end. So the reward for participation went up, and we saw increases in our response rate after our first bump up. So that's anecdotal, but I do think that made a big difference. And then again, just the customer service and the responsiveness, obviously going out to the clinics and visiting people, answering questions, making it transparent, helping make sure that clinicians understand that the data is going to the research team. We had everybody's individual email, and we emailed them directly, and they submitted their stuff on our research server. So they felt confident about, this isn't going to get looked at by my boss and I'm not going to get in trouble. There's a relationship of trust with the research team, and they are going to protect my information and do that. So that's what I would say is really relational, and all those little details play a big role. But we had really great rates on all of our surveys as far as response.
I agree. I think that the piece about the customer service is so important, and then the connection to the incentives. So we were very careful to as soon as anybody gave us any piece of data, that they received incentives. And so we try to make sure that folks got their gift cards and so forth within 24 hours. And we did electronic gift cards to the extent possible. I mean, to the extent where sometimes we would have somebody go in, if there was a 3-day weekend or something, have somebody go in and make sure that those incentives were sent out right away. And I think that helped with the follow-up data collection as well. But we also added incentives linked to timeline. So if you complete the X survey or submit whatever video by a certain amount of time, then you get the opportunity for extra incentives, which was certainly helpful. So that follow-up, the relationship with the staff, I agree with Nate, was really, really important.
Thanks. Those are great tips. I know it's always a challenge. So we had another question on the specific referent respondents referred to for climate. For example, to expected, support, or rewarded, but by who? Or what unit? You could talk about that a little bit in your 2 studies.
For ours, we said in your program, I mean, on the aim high side, we would just say in your program, and evidence-based practice. We had a separate measure that was specific to aim high or CPRT, but for climate, it was generally to evidence-based practice within the program or within the school district.
Yeah, in the wisdom trial, our reference for the climate measure were specifically in regards to the digital measurement-based care system we were using, which was the OQ system. I think I mentioned that. And we referred to the clinic level climate for our clinicians, because they were all in. We randomized at the clinic level.
Yeah, thanks. So there's another question about more specifics about the NBC fidelity measurement in the wisdom trial. But before we get to that, I just, you mentioned COVID, but I just wanted to ask both of you, because I know there were some issues like the way the grant was submitted, and then how had things changed in the service systems when you actually started doing the trial. So I know there were some issues in wisdom, and I think also in the CPRT and aim high trials as well.
So what was the effect of COVID on how that changed?
No, even before COVID.
Oh,
I mean, every trial I know of, things change from submission of the grant to actually doing it.
Yeah, there were certainly changes. We initially proposed to only recruit in LA, San Diego, LA County, San Diego County, and Sacramento counties, and needed more sites, right? We were randomizing at the program or school district level. And so one of the changes we made was to recruit across California, and we were doing some distance training before COVID, which actually helped us prepare to be more nimble once COVID hit. So we already had a distance protocol prior to COVID, just because there was logistics of actually going to any county in California was, wasn't possible. So in some ways that helped us pivot. Once the clinics and the schools opened up again, then we pivoted to remote training for everybody.
Yeah, our context, as you know, Greg, our context changed a lot with the wisdom trial. We initially had some support from the state, which they began implementing a different measurement tool right around the time that our trial started. They began implementing the cans really rigorously. So it sort of dumped this huge burden on all of our providers. And we originally thought, uh-oh, we're going to have to go outside of the state of Idaho, which is where I am, to recruit. We originally were going to recruit all of our sites in Idaho, but we decided, well, we're going to have to go outside of Idaho. At one point, we had a 4 corners recruitment strategy. We were talking about Alaska and Maine and Florida and Arizona. But we ended up deciding, no, let's give it a go with the Idaho folks. And also we reached out, we did expand to Oregon and Nevada. I can't remember, I don't think I mentioned that. And so we had sites in Idaho, Oregon, and Nevada. And that was partly in response to some of those policy shifts, right, that happened that, maybe we could have anticipated. I don't know. Maybe we should have, but we didn't, and it changed. And so that was how we responded to that.
Yeah, thanks. So there's a question about the analyses and at what level they were completed, unit level or provider level in each study, because I know data was reported at the child or family level, also provider level and clinical level. So if you could say just a little bit about that for each study.
For teams, provider and child level are the same level because they're yoked. So providers were only eligible if they had an eligible child, and the child was only eligible if they were on the caseload or in the classroom of an eligible provider. So those were yoked. So child and provider were the same level in teams, and then they were nested within a program or a school district.
Yeah, and in wisdom, the analyses I showed today, there was different kinds of nesting going on depending on what analysis we're talking about. So, but in terms of the primary outcomes, we had kids nested within clinics. That was really our main for the fidelity measure, because our fidelity measure was characterizing the episode of care that we observed in that 6-month period that we followed each youth. For the longitudinal analysis of change in youth symptoms over time, there we have observations nested within the kids, and then the kids nested within the clinics. For the analyses where we looked at change in climate and leadership over time, then we have time points nested in clinicians who are rating those things, who are then nested in their clinic. So it's kind of different nesting depending on the analysis that you're looking at, but that's the general setup.
Yeah, I should have added that we also had some repeated measures where time was within child or provider. We also have data we have not presented or really looked at yet, but leader ratings of climate and leadership and implementation support strategies. And so those are at a higher level than the providers.
Yeah, thanks. And those questions are always important, and often people don't specify that clearly. And Nate and Rebecca laying the call just led a paper published in Implementation Science on 8 issues related to doing multi-level research in implementation science. So I'll direct you to that. If and that just came out, gosh, less than a month ago or so. Pretty recently. So there's also a question here. Someone would love a little more specifics about the NBC fidelity measurement in the wisdom trial.
Fidelity in the wisdom trial. So there is a fidelity index that's been empirically validated. Len Bickman, I believe, was the first one to put that in the literature, and it's been replicated in a couple of studies. So we use that format. Essentially what it does is for each youth, it calculates the proportion of sessions in which a measure was administered, which is called a completion, and was completed, I should say, and that's called a completion rate. And then it also calculates of the measures that were completed for how many did the therapist or the clinician actually look at the feedback report. So there's a viewing rate and a completion rate for each youth. And if you take the product of those, you end up with the overall fidelity index. We figured out while we were doing that math that all of that reduces down to the number of views over the number of sessions. You can check out my algebra and verify that for yourself. But so what it really boils down to is the number of viewed feedback reports relative to the total sessions for the youth. But it's the same index that's been used in prior studies. So that's what we used.
Yeah, Manon, do you want to ask the more detailed question that you had?
Sure. Yeah, thank you. That was a really nice response. And I looked it up in the paper because I realized I could probably find that in the meantime, but that led to another question, which is, if one component of fidelity is to really use those ratings to guide clinical decision making, maybe this is more of a hypothetical question, but how might one measure that? And then how would you support that, just kind of theoretically in that sort of system? Because I imagine that's trickier to measure and also an important part.
Yeah, it is. It's a very important part. And that's a great question. And it's also the hardest thing to measure, right? Because we wanted to stick with objective, if it's in the system, we know it happened and we know when it happened. And so that's why we stuck with that. But that is a limitation, is we don't capture that data about did the clinician actually use it. We did ask clinicians about their use of measures, but it was more on those quarterly surveys. So it's not like the kind of patient level data. There's a trial by Kara Lewis where they tried to get into that a little bit, but I don't know that they ended up having a ton of success with it. I think it's a little bit of an enigma. If you have a good idea, I would love to hear about it. But I think it's just a real challenge. Unless you videotape the sessions, right? Then you could see what people are doing. But actually, even then, you don't really know. You can see what the therapist does if they talk about it, but you don't know. They may not say it out loud to the client, but they're thinking it in their brain. So it's a really pretty tricky thing to get at. But yeah.
Yeah, I don't have a good answer, and it's something I want to think about more. But thanks, that's helpful.
Yeah.
Yeah, so I want to thank our presenters. We're just about out of time. Also, I put the link to that article that I mentioned in the chat, but please also complete our brief DISC seminar evaluation. It really is very brief, and we really appreciate the feedback. And thanks again to Lauren and Nate and Aubin in her absence for doing these, kind of difficult, large-scale studies of these, organization and clinic level strategies that we need much more information on how these operate and how we can be more effective in helping clinics and organizations to effectively implement evidence-based practices. So thank you both so much for your time and great work.
It was a pleasure. Thanks for good questions, everybody.
Thanks, everyone.
Bye.
Okay, so